Good afternoon, everyone, and thank you for joining us here at Valley Children's Hospital for the next installment of our virtual health series for families. I'm Zara Arboleta, joined today by Dr. James Horspool. Good afternoon, Dr. Horspool.
Good afternoon.
You're very well known to many of our families, but for those of you watching from home, Dr. Horspool is the medical director of our Charlie Mitchell Children's Center here at Valley Children's Hospital, which provides primary care to our patients with acute conditions and other conditions, chronic medical conditions, as well as for their siblings. Dr. Horspool, again, thank you for your time. The topic today is COVID-19 and children with special needs. Before we get to all of the questions people have been sending us via Facebook and Instagram, I know that you had a few words you wanted to share with our families who are watching right now.
Yeah, thank you, Sarah. I think the first thing I wanted to say really was, as I reviewed these questions, it seems like most of the people out there in the community have the same question that all of us have. What is my personal risk and what is the risk of my family members? And unfortunately, that's a very difficult thing to nail down. And I think it's important to remember that this is it's not a new category of disease, but this specific disease, the COVID-19 illness, has gone around the world and back again in less than a year. So we really don't have a lot of experience time-wise to see how this plays out. And the doctors and the scientists have been trying to assemble data. But it was interesting, a month or so ago, our infectious disease doctor gave a noontime talk about this condition. He said, I think this is the first talk I've ever given where I'm referencing papers from a month ago that are now out of date. And so we're still learning about this, and it's very difficult to make general statements that apply to everybody, whether or not they have underlying health conditions. And so when you get down to the individual health condition of your child, then it becomes even more difficult, because the fact of the matter is we simply don't have a large body of data about how this disease affects children with certain types of medical conditions. And that's one of the things that we struggle with at the Charlie Mitchell Clinic on a fairly regular basis. How do you assign risk and data when you have this population of children that is kind of unusual over the greater population? So just in general, as I think most of you know, COVID-19 is primarily a respiratory illness. That is, the worst complications we see, the things that cause the worst kinds of problems medically, are respiratory problems, breathing difficulties, and the primary route of spread is through respiratory droplets, coughing, sneezing, bits of saliva that get airborne. However, as most of you probably also know, there are other symptoms and other signs and other potential complications, and other ways to spread this, including through contact. But I think keeping those things in mind will be helpful as we move forward with our discussion. And a couple of other things I wanted to mention. A number of people submitted questions asking about risks or how they deal with their special needs child. And that's an interesting term. We use that term fairly liberally, but in fact, when you say special needs child, that probably means very specific things to you, because that conjures up pictures of your own child or your own children. And in fact, special needs, there are of course a variety of needs, and all of them special for children who are developmentally normal and those who are not. And so it's very difficult to answer questions like that specifically, but I will try and address things as much as possible and talk about what we don't know, as well as talk about what we know that we can do to be helpful.
All right, thank you, Dr. Horspool. For those of you just joining us, feel free to submit your questions in a multitude of ways, either here on Facebook in the comment section. You can tweet us, Care for Kids, or you can send us questions via our Instagram Valley Children's account. Masks are a huge question. We always get lots of questions when we do these segments, Dr. Horspool, about masks, because it is mandated that people should wear that people really do need to wear these out in public, and when social distancing is not possible. Getting a lot of questions. Is it safe for children with special needs to even wear masks?
Okay, that's an excellent question. And I'd like to address a couple of different aspects of that, not only that specific question, but a couple of other things that oftentimes come up. First of all, remembering that COVID-19 is primarily a respiratory illness, and it's primarily spread by respiratory droplet, then that should lead to the logical conclusion that wearing a mask mostly prevents or protects you from my droplets. It doesn't protect me from yours as much as your mask protects me from yours. And so wearing a mask in public does help reduce the spread. We know that. Furthermore, wearing a mask is not so much an issue of protecting yourself as it is protecting those around you. And so in that respect, wearing a mask becomes an act of compassion and consideration of each other. So the question about safety, I've heard people on the news venting and spewing about how these masks are killing people. They are literally threatening our lives. We have accepted as common sense for decades that when you go into an operating room for a surgical procedure, or you do an invasive surgical procedure in any context, wearing a mask helps prevent contamination of the wound and contamination of the patient. We have yet to see doctors, nurses, and other OR attendants die from wearing those masks, sometimes during surgeries that last for many hours. We know that sometimes OR nurses get bladder infections from not being able to go to the bathroom often enough, and the medical industry has taken steps to alleviate that. But we have not had people die from wearing masks in the operating room. And I think we can be fairly reassured that wearing a mask would not kill you. Now, as to the question of special needs children, special needs, again, is such a broad term. And so I saw a young man in clinic today who was wearing his mask very diligently, but below the mask, he had a tracheostomy. Well, that's another place where he can spread respiratory droplets. But he had a cap on his trach, and he was one that could tolerate it. I think in most cases, wearing a mask will not be medically harmful to special needs children, whatever their particular medical conditions or needs are. What we have accepted as a medical community at face value is that there are some children who we will just not be able to keep masks on them. And we accept that as part of common sense. And so that underscores the fact that the rest of us who can wear masks and be responsible that way need to be that much more diligent to protect those children who we can't keep masks on.
So speaking of masks, someone just wrote a question through Facebook and said, for our kids who have lung disease, are oxygen dependent is needed, and don't neurologically understand wearing a mask, how do you help those children, and how do you help their parents deal with some of the issues they might face when having to take their children out in public, for instance, to an appointment with you, or at the hospital for lab work or something like that?
Yeah, that's a great question. And depending on the mechanism of oxygen delivery, if it's just nasal cannula, that shouldn't get in the way of putting a mask over the child's face. But again, there are some children who are neurologically impaired and simply are not going to be able to keep the mask on. They'll bat it off, or they'll twist their head, and you can give yourself an ulcer trying to keep that mask on. And I think the best advice I can give is to wear your masks, keep as distant from other people as possible, and do what you can do. When you come in, respect those distancing markers that they have at the entrance to the hospitals, and an awful lot of stores that I've seen as well, businesses of various sorts. And if your child really can't keep the mask on, bear in mind that mostly the mask protects me from sharing my germs with you. And so you're not putting the child at especially increased danger because the child can't keep the mask on. The mask is to protect the mask wearer from spreading germs to others. Not to be overly gross, but one of my daughters who was having a bit of a spirited discussion with a friend over masks, she said, well, you know, if someone pees on you, that's really gross and nobody likes that. If you wear pants, it helps create a little bit of a barrier. If they wear pants, it's even better. And I think that's a great visual to keep in mind.
Dr. Horspool, I love how you don't mince words. It makes me happy, and I think it gets your point across very effectively. So thank you for that very vivid example. But you're absolutely right. Here's a question for you. Are children, and I know what you're going to say already, but are children with cerebral palsy and epilepsy better off staying home and even missing therapy appointments?
Great question. And again, it kind of depends, and every week, each one of us in the Charlie Mitchell Clinic gets our patient list for the subsequent week, and we go through our patient list and we do a risk-benefit consideration. How critical is it that I need to see this patient in person, or could I accomplish essentially the same thing through a video visit or just through a telephone call? And so for someone with cerebral palsy or epilepsy, how critical is the therapy? Is the therapy something that they're getting that is preventing irreversible contractures in their limbs? Or are they in the middle of a process that would go dramatically backward if it was interrupted? And so you have to kind of do a risk-benefit analysis for that. And really that's best made with the individual parent who knows the child the best. And I always say, when in doubt, give the doctor or the therapist a call and say, gee, what do you think? And then again, cerebral palsy, again, it seems like a specific term, but it's fairly broad in terms of its connection and relationship with many other conditions. And many children with cerebral palsy have chronic respiratory problems, some do not. And so the respiratory problems put them at a little bit more risk for complications. And so again, a judgment call, but the epilepsy per se is probably not a serious risk factor for COVID, although every other underlying condition makes the potential for complications greater.
And this question just came in seconds ago. Due to COVID-19, should we postpone non-invasive scans or tests if at this time they are just routine?
Great question. And we've asked that question many times over since the beginning of March, institution-wide here at Valley Children's. And again, it depends on what you're expecting. And in fact, one of the first things we did as an institution, as you know, Zara, was cancel all elective surgeries and procedures and wait to see what precautions we needed to put in place and what other kinds of adjustments we needed to make. And now we've slowly been rescheduling these procedures and scans and so forth. And so, for example, if you were supposed to have your scan in January, but it got postponed for something or other, and now you're supposed to have a scan every 2 years, and now it's been 3 years, you may want to discuss with your doctor whether we need to get that scan done. If, on the other hand, you're getting your scans every 3 months and everything's been normal up until now, you may want to postpone for a little bit and see if the dust settles out a little better. But again, I think it's never wrong to call your doctor and ask for advice.
We had, for one of our previous segments, Dr. Carmela Sosa, one of your colleagues there at the Charlie Mitchell Children's Center, also a medical director of primary care. One thing she was saying, though, was for everybody, you should stay on track when it comes to your immunizations and those types of appointments. Is that still the case there at Charlie Mitchell, that you want these kids to stay on track of the different shots they're supposed to get, especially with school starting, however school looks, but with school starting up again?
Yeah, absolutely. From the very beginning at Charlie Mitchell, we sat down as a group and discussed what things were important enough to bring children in. And immunizations was across the board agreed upon as something definitely worth the risk of exposure. And just last week, I was reading some consensus reports from different pockets around the country of groups associated with children's tertiary care facilities. And that seemed to be the broad consensus among all groups, is that the immunizations were more important. That is, going unimmunized was a greater risk than coming out to clinic to get your immunizations, particularly in the pre-kindergarten era, the 0 to 4 years old, 0 to 5 years old. And additionally, it's really even safer coming out now because we've all done so much to reduce the traffic in our waiting rooms and our clinics. So your exposure on any given day that you come out is going to be less than it would have been, say, last January or February.
All right, for those of you just tuning in, I'm here with Dr. James Horspool, Medical Director of Valley Children's Charlie Mitchell Children's Center, taking your questions right now on Facebook, Instagram, and Twitter. Let's get to some specific questions. There is somebody who turned in a question last week asking, are micro preemies considered high risk if they have no lung or heart issues?
Good question. Another question that seems very specific until you start looking at the variety of micropreemies. Micropreemie is a term that if you start looking up definitions, you'll find a variety of definitions, but most sources refer to micropreemies as babies that were born before 26 or 28 weeks of gestation, 40 being term, or babies that are born less than 1,000, or some say less than 800 grams. First of all, I'll say it's pretty unusual for a micropreemie to go through the whole premature birth and NICU course without having some respiratory issues, problems. But I think depending on how old the micropreemie is, for example, somebody who was born at 26 weeks gestation at 600 grams or 800 grams and now is 12 years old and doing normal things like normal kids, probably much less. On the other hand, if the child is under 1 or 2 years of age, we sort of think that there are some inherent vulnerabilities still, even though the child may not be on a lot of respiratory medications.
All right, another question. Are there any links between COVID-19 and 1Q21.1 microduplication? I don't know if I said that right.
Not that I'm aware of. I did see that question and thought about it quite a bit when it was forwarded to me earlier this week. And that whole category of microdeletions and microduplications is a category that we didn't even have maybe 10 years ago. The molecular science has progressed so rapidly over the last 10 to 20 years, and we've developed these molecular techniques to find these little minor gene anomalies. And the trouble is, the technology has advanced so rapidly that we really don't have a database of people with individual minor abnormalities to associate them with clinical syndromes. And so we don't know if some of them are significant and some of them aren't, or not in many cases. And it's interesting that if the computer technology had not evolved along with, in parallel to, the molecular technology, we wouldn't be able to do anything with the molecular technology, because we need the computer to scan those gene sequences and even find those things. Nobody could manually go through the millions of genes and find those little minor abnormalities. So we don't really know about those minor, I don't mean minor in the clinical sense, but small variations in the genetic sequence. And until we get a large body of children that have that same anomaly and compare how they do clinically, it's going to be difficult to make predictions.
We're getting several questions coming in from families with children with autism spectrum disorder. And so there are several questions about how would the hospital deal with a nonverbal autistic child with COVID-19? How do you help them adjust to wearing a mask? And just in general, how do you help support children with autism during this very scary time?
Yeah, That's a tough one. And again, it's all those who have association with children with autism know that there is a very broad spectrum of severity in autistic disorders. And I think one of the most beautiful things that the Valley Children's Organization has done in recent years is create the George Pass, so that the children with autistic problems don't have to sit in the same line and endure the same kind of wait and the same milieu in the environment as the other children do. And they've got them sort of a fast pass routed into a quieter environment. And I think that's incredibly helpful. In terms of how one deals with the child who gets the illness and has to endure isolation and whatnot, that's a huge challenge. And unfortunately, I don't have a magic bullet answer, but it kind of comes back to what I kind of wanted to, as I thought about what I would talk about today, what I kind of wanted to end up with. In the end and all, there are two important things that I think need to be engaged when you figure out, as you decide how to best care for your child in this pandemic situation. And that is, number one, common sense. And number two, your own intimate familiarity with your child and his or her unique qualities and vulnerabilities and behaviors. And people are, if you don't mind me sort of veering into another area that I know is coming up, and that is how you know when to take your child to the doctor or to the emergency room or to the clinic. And I think it comes down to some common sense. If there are respiratory symptoms, but they seem minor, then you treat it like you would any other respiratory illness with symptomatic treatment and manage at home as you would normally do. And if it becomes more severe, that makes enough to make you nervous about how your child is doing respiratory wise, just as with any other respiratory illness, whether it be a cold or flu or asthma, then that's when you would take your child in for medical attention. And again, interestingly, one of the exasperating things about this COVID-19 illness is that it's produced some other rather bizarre associations and symptoms that don't necessarily seem to have a correlation with a respiratory illness. And so when you see something that makes you uneasy because this is not my child and this is not how he or she usually acts and responds, that should give you enough angst and motivation to either call the doctor and ask for advice or take your child in to be seen.
I think that's what is so difficult, because I've got two little ones at home. One has chronic asthma and allergies. So for a lot of parents, especially those with children with special needs, the symptoms of allergies, asthma, a cold, flu, COVID-19, all the other coronaviruses floating out there, they're all so similar. And so it becomes overwhelming. And every time one of my kids coughs, it's really hard not to go to that, oh my gosh, they need to get tested for COVID-19. So do you want to explain just a little bit? I know you kind of touched on it just now, but how can you tell? Because that's a question we get all the time. How can you tell, especially when our air quality is terrible half the time here in the Central Valley?
Yeah, and I've been emphasizing to my patients since early March. This is a really great time to make sure your asthma and allergies are in exquisite control, because if you cough, you and everybody else around you is going to freak out and think you have COVID-19. And early on in the pandemic, as it came into this country and emotions ran high, I would see people on the news getting frustrated, going to 2 or 3 different ERs trying to get their child tested, and the testing becomes almost superfluous in terms of what you're going to do about it, except for isolation, because we don't have so far a specific treatment. There are a lot of treatments that are being tested, a lot of treatments that are coming into development, but as we sit right now, we don't have a automatic, if you get this, you get better treatment for COVID-19. And so again, I think it comes back to some common sense and for knowing your child. And if your child's having more difficulty breathing than you're comfortable with, whether it's asthma, whether it's COVID-19, whether it's a cold, then that's the time to seek medical attention.
We're getting quite a few questions from people saying, let's say my child gets COVID-19 and has to be admitted into the hospital. Will my child have to stay in isolation? And can caregivers, can parents join them in their rooms, or is the child completely isolated the entire time they're here?
Yeah, the answer to both those questions is yes, the child will need to remain in isolation. And yes, caregivers are allowed to be with the child. And that's a great question and an important one. And I think it's kind of interesting. My life and career have been kind of unusual. I got into my profession a little bit late and got into my rather large family a little bit early. And so I spent a lot of my post-training years moonlighting at various and sundry jobs. And I remember one night I was in an ER where I had a moonlighting job one night, and right at the usual time, around 8 o'clock or so, this kind of annoying nasally voice would come over the PA and say, "It is now 8:10, our visiting hours ended at 8. And I kind of muttered under my breath to the nurse who was helping, "So get the heck out of our hospital." And I think that's one of the great lessons that children's hospitals have learned, is that having parents here to help to attend their children is not an annoyance. It's not an interference. It's actually a great help. It's a huge help. And I commented to that, where I said, pediatric nurses in hospitals, they don't want the parents to go home. Their workload doubles as soon as the parents go home. And the child is more fussy. There's lots more to do. And it's great to have parents here. As you know, the hospital has made a decision to restrict child visitors to one caregiver at a time. So mom and dad and the brother and sister can't be in there visiting. And I had a patient who was up in another area having some major surgery recently, and his mom told me it was very hard on him because he wanted his sister to come in visit him, and she couldn't. It was mom or dad, and they had to spell off. And that's kind of pretty much a universal policy in hospitals across the country.
And a reminder to those of you watching at home, Valley Children's has instituted some pretty strict screening protocols at all of our entrances to all of our facilities. Everybody needs to be temperature checked. They have to be checked for symptoms. But again, there was this big fear because we see in the news, Dr. Horspool, these adults in adult facilities, obviously, who are by themselves the entire time. But like you said, at Valley Children's, that is not the case. Moms, dads, caregivers are allowed in one at a time. Yeah. Another question, let's see, what kinds of things should I do to protect my wheelchair-bound 5-year-old who has hydrocephalus and it says chair 2 malformation?
Chiari 2?
Chiari 2 malformation.
Okay.
Yeah.
Well, could I just circle back to a part of the question about the autism? One of the things that I wanted to mention, a lot of children with autistic tendencies have different sorts of tolerances to different things. And I think if keeping a mask on your autistic child becomes such a hassle and a frustration to you and the child, then it's probably not worth it. And again, bearing in mind that the mask is more to protect other people from the mask wearer's germs. And so you're not being a bad parent and exposing your children to the death-defying plague by not keeping a mask on them. So anyway, so Chiari 2 and wheelchair bound. Well, first of all, Chiari 2, for those who don't know, is a malformation in the back of the brain that oftentimes interferes with the draining of the cerebral spinal fluid out of the brain and down into the spinal column and later dissipated into the body where it's absorbed. And so while it's not necessarily a slam dunk, it's not uncommon for people with Chiari malformations to develop hydrocephalus because the spinal fluid doesn't drain enough. And so the head tends to expand, and they have to have special hardware put in to help drain the fluid through another route, through a surgically installed shunt and drain system. The big thing about wheelchair-bound children and those with Chiari malformation and those without is that they are less mobile. I don't know that that makes them more vulnerable to catching COVID-19, but if they get it, it makes it more difficult to ventilate effectively because they just don't move, and they don't move air as well as if they were walking and running and playing normally. So to the specific question of what you can do to protect your child, again, the common sense things. Don't go to birthday parties with a bunch of people around. Don't go to places where there are going to be a lot of people in close proximity. Observe social distancing, wash hands, cover your face when you cough or sneeze, and just observe basic rules of common sense and cleanliness and disease prevention. And again, I think not getting an ulcer about whether you're doing absolutely everything, but do the basic common sense things.
A question came in via Facebook. With the upcoming flu RSV season upon us amidst COVID, what are some of your top 1 or 2 recommendations, Dr. Horspool, to keeping our special needs children as safe as possible and avoiding ER visits, realizing that all kids have very different needs?
Well, we've discussed that here locally, and it's a topic of hot discussion across the country in the medical profession. And I think we're all living in a little bit of dread fear about layering this COVID-19 pandemic on top of the normal cold and flu season. I think the first thing to do is to do everything else you can reasonably to keep well. If your child has asthma or allergies, keep them tuned up. Don't slack off on medications just because they seem okay today. If they have a history of recurrent flare-ups and the doctors decided that those flare-ups were severe enough or frequent enough to put you on some controller or prevention medicines, take those exquisitely. If you're running out, call in for refills. And then the next thing, again, in terms of preventing unnecessary illness, get the flu shot. There's lots of debates and a little bit of superstition about flu shots, but the data are clear. You hear discussions every year about whether this year's flu shot was as effective as another year's flu shot. So every spring, the epidemiologists and the infectious disease people in the country get together and they look at flu strains that predominated last winter and the migration patterns worldwide, and take their best guess at predicting what flu strains are going to predominate this winter. And then they give that information to the vaccine manufacturers and they make a flu shot. So sometimes they get a bullseye, sometimes they don't. But year after year, what statistics have shown is that the people who get sick enough with influenza to actually require hospitalization, require ICU care, or in some cases suffer death, of that group, only about 2 to 5% had the flu shot. And so from a basic clinical outcomes standpoint, you could argue that the flu shot is better than 95% effective at preventing serious illness or death.
That's a pretty stark statistic.
Yeah.
It really does sell the fact you better get a flu shot and get your kids their flu shots too. That normally happens early fall. Is that when they start?
Yeah, typically we start getting the flu vaccine shipments in around September, October.
Okay. Here's an interesting question. And in all the months we've been doing these, never got this one. So the first part is new. My son has pulmonary obstructive and restrictive airway disease, as well as heart issues. Here's a really interesting part of this question. We are so isolated. Is it possible to be too isolated?
Great question. And it's one of the things that has prompted a lot of people in the medical field even, to recommend schools reopening before the numbers would seem to justify the validity of that recommendation. And really that comes down to your own personal, social, family strength and resources. And unfortunately, in my opinion, one of the difficulties that we've seen in our social evolution is loss of those kinds of family connections and family home life that we used to see on, Leave It to Beaver and My Three Sons and those kinds of things. But whether that was a myth back then, I don't know. But I think it's critically important in that situation to consider what you might do to cultivate resources within your family, within your home, and then virtually also, and being creative with whatever resources you may have. I just was speaking earlier with you about, and some of your colleagues, about one of my special needs patients who had a Zoom interview yesterday, and heard that he was just over the moon. He's very neurologically, developmentally impaired, but he was over the moon about being able to be on Zoom and see those faces, and that was just a real kick for him. And so there may be some of those kinds of resources, but I think for people who are feeling a little too isolated, that is a potential danger. It's not a medical danger so much as a social emotional danger, which can ultimately become a medical issue. So I think cultivating resources within your family, figuring out things that you can do with your isolated child to make him or her feel special and involved and engage his or her brain and fun centers, and building relationships. I heard something on the news a few weeks ago when one of the states opened up their bars, and some guy was being interviewed, and he said, yeah, I've just been at home with me and my fiance, and we're driving each other crazy. And we all kind of looked at each other in our family and said, well, that doesn't prognosticate very well for this relationship long term. And so find the good things about each other and reinforce those, and find activities that you can do in your home that will reinforce those, and then reach out to friends and extended family virtually and figure out things. I know several of my grandkids are getting together virtually once a week to share stories they've written, and they call it Creative Cousins. And the cousins each take turns moderating or mediating the session each week, and it's just something else that they've done to give them an outlet.
So we are getting along these same lines. We are getting so many questions about schools reopening. Valley Children's position is, obviously, children are better off in school, developmentally, socially, behaviorally. They're better off with other kids. They're better off in that setting, but only when it is safe enough for everybody to be back in the classroom and in person. We are getting so many questions now saying, when schools do start in-person classes, is it okay? And what is your recommendation for parents of children with special needs? What should they do? Is it okay to send their kids back to school when they are already part of a very immunocompromised set of people?
Yeah, or vulnerable. Yeah, whether you're
vulnerable. Yes, thank you. Thank you.
Yeah, we again in the Charlie Mitchell Clinic, we've discussed this at fair length, and I think again. I like to think of myself as a sort of a simple-minded guy, because we've heard a lot of conflicting recommendations, and some of them from prominent people in the medical profession. But in March and early April, when we were all hunkering down, our numbers went down. When we started opening up and getting lax, the numbers went back up. Well, I'm a simple guy. That tells me this disease is not ready to let up if we relax. And so, first of all, I personally would not recommend sending kids back to school willy-nilly until we see a clear trend of the COVID new cases and hospital admissions and so forth going down. Next, I think it only makes sense because every other industry is opening up in phases. Low risk first, going to higher risk. And I think it makes sense to send kids back to school in the same manner. Low risk children without vulnerabilities and without close proximity or close exposure to those with high vulnerability should go back first. And the next wave should probably be children that have no particular vulnerabilities themselves, but perhaps have exposure to siblings or other people close to them that have vulnerabilities. And the very last group that would go back, I think, would be people with severe respiratory problems, people with tracheostomies that need to be suctioned, because that presents a hazard to them and a hazard to the people who have to provide the care, because just the act of caring for that patient involves aerosolization of saliva and so forth, and an inherent risk. And so, number one, I think the schools have to be able to, number one, we have to see a clear trend with the numbers going down to sensibly recommend that children go back to school in person. Number two, we have to be assured, the schools have to feel comfortable that they can provide the protection and the care that the students need in terms of minimizing infectious risk and spread, both in between the children and to the teachers and staff. And then thirdly, we really need to see the trend continue as schools open up. I think actually Governor Newsom gave a very nicely laid out tactical plan in that respect.
Okay. We're getting lots of questions about testing. Specifically, someone has had a child come in, get tested. We are testing children who come in presenting with COVID-19 symptoms or known exposure. We are also testing kids before all surgeries. But some people are asking, if my child tests positive, we're sent home because they don't need hospitalization. After that 14-day period of isolation, can the child automatically come back and get retested? What are the, I don't know if you know the answer to this one, what are the protocols for retesting?
Everything I've read and discussed with my colleagues here, there is not a uniform recommendation for retesting. It's not like if you get some infection and you get an infection in your bloodstream and you need to have a negative culture to prove that the infection is no longer there. I think if you see resolution of symptoms and you've been in isolation for 14 days and symptoms have completely resolved, then I think it's reasonably safe to resume normal life, well, as normal as we can be in this circumstance, without going and getting retested. There isn't, to anything I've read or heard from any of my colleagues here, a uniform recommendation to be retested. Some people do get retested because they're in particularly vulnerable environments and they're particularly vulnerable people.
And for those of you,
I'd say that mostly I've heard that in the context of people who test positive in nursing homes, but they're not severely symptomatic. And so people want to know when we can allow them to mingle again within the nursing home.
And something we did want to point out, because we're seeing a lot of people come in, Valley Children's is not a community testing site. But on our website, for those of you watching at home, if you go to valleychildrens.org/COVID-19, so our main website /COVID-19, we have a list of centers around the entire Central Valley that do offer testing, low cost and no cost as well. So look on there. But of course, if you have symptoms that require medical care and you need to go to an emergency department, yes, come here to get your child seen, and we will certainly treat them. There are a few people who are saying, are we suppressing our children's immune systems by continuing to isolate? What is your opinion on this, Dr. Horspool?
No, you're not doing anything to your child's immune system. His or her immune system is what it is. There is some discussion in the medical literature, and has been for several years, about perhaps children are a little more vulnerable. We know that asthma has been on the rise for many years, and many allergies, and people have speculated that it's this super cleanliness environment that we have in our Western civilized urban society that has kept kids from getting the regular childhood illnesses, and their immune systems are not as robust as children, say 50 or 100 years ago. But I took a U.S. history class, my last community college class, before going back to school full time in my late 20s. And I learned some interesting statistics. 200 years ago, the infant mortality rate in childbirth was 25%. The maternal mortality rate in childbirth was 25%. The child mortality rate by age 10 was 50%. And so, yes, women could have babies without doctors, and most did, and the population kept increasing, but an awful lot of people died. And we in the 21st century tend to attach, especially here at Valley Children's, I think, attach importance to each individual life. And so you may be exposing your child's immune system to an opportunity to become more robust and develop more immunity, but you may also be exposing your child to an opportunity to catch a disease that could end up being fatal. And while most children, the vast majority of children, do not have severe symptoms, certainly there is no guarantee, and there is no, you don't get any King's X. When I see a new baby in clinic, I have a little spiel that I give to mothers of new babies, whether this is their first one or their 10th one. And one of the things I kind of end up with is I say, you know, parenting is a lot like doctoring. It's a high stakes game. We all desperately want a good outcome, but you don't get any guarantees and you don't get any do-overs. So what can you do? Well, you can protect yourself against what I like to call the what if I syndrome, where something goes bad and you go, oh, what if I only did this? Or what if I hadn't done that? And so we use the car seats, we fasten our seat belts, we get our immunizations, and then if something bad happens, you say, you know what, I did everything I could. And sometimes stuff just happens.
The guilt for parents, as you know, can be overwhelming at times, especially when all we want to do is protect our kids. You know, so many questions coming in. There's another one here. A mom writes, my daughter has fragile blood vessels as part of her genetic mutation. I've seen studies about how COVID-19 can cause bleeding in the lungs and other parts of the body, as well as blood clots. Does this put her at higher risk since she cannot take NSAIDs? Oh,
okay. NSAID, NSAIDs, as we call them, is the class of medicines that includes ibuprofen or Motrin, Advil, naproxen. And they are wonderful pain relievers and fever reducers, but they do interfere with blood clotting. And so again, with respect to COVID-19, that's a really tough question, because some of the adult literature suggests that the very sick patients with COVID-19 did better when they were put on anticoagulants and anti-inflammatories early on in the course of the disease, the course of treatment. I think in the case of this particular child, I think it's unlikely that the child is at increased risk for getting the disease, but probably would be at increased risk for complications should she get the disease. So that just underscores the importance of backing up prevention. Someone once said it's better to prepare and prevent than to repair and repent. And so, and certainly that applies in this context.
That's a good one. Many of the children you see not only go to your clinic, but to the various specialties at Valley Children's throughout the network. Someone writes, I'm worried about all of the clinics that we regularly have to attend there at Valley Children's. Do you have a plan for the kids on trachs and vents during the winter? I am freaking out about winter.
If you're going to freak out about something, that's probably a good thing to freak out about. But I know about 2 or 3 months ago, I was talking with a mom who was asking me if I need to panic. And I said, well, given that the therapeutic value of panicking is very low, I would say, no, don't panic. So a child with a trach, a child on a ventilator, has a very vulnerable respiratory system by definition. And so again, is going to be highly vulnerable. Again, at high risk for, should they get a respiratory illness, of sharing that respiratory illness with others, because they have this open tracheostomy and it has to be suctioned periodically and so forth. But again, we come back to trying to prevent, and I think all of us here at Valley Children's are trying to do the best we can at figuring out what patients can be seen as efficiently or effectively or nearly as effectively through a video conference as having them come into clinic. And again, as you mentioned, we are screening at the doors of all entrances at Valley Children's facilities and taking temperatures, asking about history and exposures and symptoms. And so the people that make it past the screening are a much healthier group than we normally see. And so to the parent with the child that has chronic severe respiratory problems, especially with tracheostomies and ventilators, I say, freaking out will not help, and that's easier said than done. But again, take the precautionary measures, watch close, use your common sense, use your intimate familiarity with your own child's day-to-day condition. And when you see things changing, call and ask for advice, ask for help. And then in terms of coming into the clinic visits, have that discussion with your doctor about whether a video visit would be just as effective as a in-person in the clinic visit. And as I said earlier, I think every week each of us goes through our schedule for the succeeding week and decides which children could probably be seen just as effectively through a video visit, or which ones really need to come in for one reason or another. And those are various reasons, not just to get vaccines, but I always, when I turn my list back to the people at the front of our clinic to rearrange the appointments, I always write anyone that is scheduled for an in-person visit who feels uncomfortable would rather convert to a video visit, or anybody who's scheduled for a video visit who really wants to come in person. I'm happy to accommodate all those people.
Okay, thank you, Dr. Horspool. We have time for just a couple more. We've received a handful of questions from people asking about the effects of COVID-19 on children with heart conditions, and especially kids who take heart medications as well.
Okay. Again, I think this is a category that doesn't make you inherently at increased risk for catching the disease, but it certainly makes you more at risk for a severe course and complications if you should catch it. So that underscores the importance of doing reasonable things that you can to avoid exposure and to prevent catching the disease.
And there was one more here. A grandma writes, my grandson had RSV at 1 month old. Does that make him susceptible to COVID? Or same thing as you said, doesn't make it it doesn't increase his risk of catching it, but if he does get it, could there be complications?
Yeah, most people think, and there's been this ongoing debate since I was in training many years ago, about whether RSV caused other conditions like asthma and chronic respiratory problems, or whether it just identified those who were already at risk for such things. And I don't know that anybody's really resolved that question. If you get respiratory syncytial virus or bronchiolitis at a very young age, you are at inherently increased risk for some scarring and inflammatory changes in your lungs. However, as you have good respiratory care, much of that can repair itself. So depending on how old that grandchild is now and what the course has been since then, if you got RSV and then emerged as an asthma patient and you weren't real diligent at taking your control or asthma medications, you may well have some airway modification that will make you more vulnerable to, as you say, not necessarily catching the disease, but to have a more severe course and more complicated course if you should catch it.
Coming up on the close of this hour, and I know you're a very, very, very busy man. Any final thoughts you want to share with our families who are watching at home right now?
Just a couple of things. I know some of the questions came in that haven't come up in this discussion, but several people asked about children with Down syndrome, and that's children with Down syndrome have a whole bunch of different possible complications. And I think we've talked about respiratory things, and we've talked about behavioral things and developmental things and heart things. And I think all the same principles apply to those. And I just wanted to cover that for people who asked about their children with Down syndrome. And then somebody else asked about hand washing. How can I get teach my special needs child or my young child to wash hands? And well, again, like wearing masks, sometimes you just can't. And so you use your hand sanitizer and you put your hands on their hands and sanitize them, and you do the best you can. and take reasonable precautions. And I think, again, coming back to exercising some common sense and not try to argue yourself out of what is obvious common sense medical data, and trusting your own familiarity with your own child. And when something, even though you can't really explain it in your own mind, if something is not seeming right, and this is, my child is not acting the way he or she normally does, that's the time to ask for some help.
So Dr. Horspool, we always get a lot of positive comments during these segments, but I have to say, I think you've set the record for the amount of people on Facebook saying, "Hi, Dr. Horspool. I love you, Dr. Horspool. Can we do another segment with you, Dr. Horspool?" So I want to pass along, you've got a fan base out there, very appreciative of not only your work today, but the work you do every day here at Valley Children's.
Well, thank you very much. That's very kind of you. And all those other people who are messaging you.
You're very popular, and you're very beloved by your patients and families. So thank you. Again, we were joined today by Dr. James Horspool, the medical director of our Charlie Mitchell Children's Center here at Valley Children's. For those of you who are looking for any type of information at all on COVID-19, Valley Children's has made it very easy for you to find information. We have a whole section dedicated on our website. Just go to valleychildrens.org/COVID-19 right there at the top of your screen. And also every day we have registered nurses who are answering your questions on our COVID-19 hotline. The local number, if you live in the Fresno area in the 559 area code, is 353-3333. And then you can also call toll free at 888-286-9336. All of our virtual health series segments are saved on our Valley Children's Facebook page. The last one we did on asthma, there are a lot of questions submitted here today about asthma. We did not get to those. Please feel free to look up the last video we did where Dr. Roberto, one of our pediatric pulmonologists, answered all of those questions. Stay tuned. We're going to have another one of these next week. We're going to have Mr. Popularity, Dr. Horspool, on. I'm already recruiting you for another one, Dr. Horspool. We'll have you on again soon to answer your questions. Stay safe, wear your mask, wash your hands. We'll see you here next time. Thank you, everybody.